Bismillah ar-Rahman ar-Rahim. So I have no disclosure. By the end of this session, you will be able to understand the standard scan of the hand and wrist region, the scanning technique and so on, anatomy, and finally some pathological finding in the hand and wrist. So before moving to the ultrasound or sono anatomy, you need to know some anatomical facts related to the hand and wrist. So first of all, the bones. I think we all know the bones of the hand and wrist, so no need to spend time for the sake of the time. Then it's important to identify the extensor tendon. We all know that the extensor tendon at the site of the wrist joint is covered by the synovial sheath. So at this site, we can nominate it as tenosynovitis. However, the extension of the extensor tendon, are continuing at flattened at the side of the MCB joint, then two slings to be inserted into the DIB or base of the terminal phalanx and the central sling in the middle phalanx. And the extension from the extensor tendon around the base of the MCB joint is considered as some sort of stabilization of the extensor tendon, which is known as the extensor hood. Extensor hood by this extension toward the sagittal bands for more stabilization during the extension. Moving to the flexor tendon, which is covered. So moving to the flexor tendon, which is covered as well in the wrist joint with synovial sheath and extended at the side of the MCB, BIB, and DIB, also synovial sheaths. So here you can mention tenosynovitis other than the extensor tendon, which is paratendonitis. These tendons are two tendons, as we all know, the flexor digitorum profundus and flexor digitorum superficialis. Profundus is going through the two slings of the superficialis to be inserted at the base of the terminal phalanx. However, the superficialis is inserted in the middle. These are considered as epithelial parts which can be scanned also in ultrasound. The stabilization of this flexor tendon in place is maintained by the thickening of the synovial sheath at the site of the MCB, which is A1 volley, the site of trigger finger, or we all know as thickening A1 volley inducing trigger finger in diabetes, idiopathic or hypothyroidism. Then we have A2, A3, A4, A5, these maintaining the stabilization of the tendon in place. However, the cruciates are maintaining the blood supply relaxed during flexion. So the most important key points for scanning of the hand and wrist is to set up your machine for the proper transducer. High frequency transducer is needed. Hockey stick can also be used. However, it's small footprint, so it can be used in the small joints, not in the large space area. And relaxed wrist and hand joints. What are the standard technique of the wrist joint? Only you need to volar and dorsal, longitudinal and transverse scan. But be sure that you scan all the areas, radial, medial and ulnar. Your checklist to be scanned in this joints is the carpal tunnel and median nerve as well as flexor tendon in the volar aspect. However, in dorsal aspect, you need to scan the 6th compartment of the wrist as well as the distal radioulnar joint. The scanning technique needs to have a better image acquisition, so you need to have proper patient position, bony landmark, and probe position. In case of the wrist joint, you need to put the hand, in case of volar or palmar scanning of the wrist joint, you need to put the hand dorsal aspect or supinated, and the probe as the black mark here, and the entrance of the carpal tunnel between the scaphoid, tubercle, and pisiform. This is scaphoid, tubercle, and pisiform. And this is the hypoechoic line represented by the arrowhead represent the retinaculum, flexor retinaculum. Underneath, you can appreciate the flexor digitorum superficialis and profundus and flexor pollicis longus. On top, there is a superficial hypoechoic structure, fascicular in pattern, which is the median nerve. Moving more distally, for the carpal tunnel, You can appreciate the flattening of the retinaculum represented by the arrowhead. This is the median nerve underneath and the flexor tendon as well between the trapezium and hook of Hamid. Confirm your finding by longitudinal scan. You can appreciate the median nerve on the top of the flexor tendons, and it looks like slightly hypoechoic in comparison to the flexor tendon. So the sixth compartment also need to be scanned for identification of any tendinopathy or in case of tenosynovitis, in case of inflammatory arthritis as rheumatoid arthritis. So we have 6 compartments. First compartment, you need to put the patient position midway between pronation and supination, which is the radial aspect facing up to scan the abductor pollicis longus and extensor pollicis brevis for de Quervain syndrome in case of tendinopathy. These are the tendons. Another important bony landmark you should be minded with the Lister tubercle. While you're scanning the dorsal aspect of the hand, you can appreciate this prominence of Lister tubercle, which separates the second compartment from the third compartment. Second compartment containing the extensor carpi radialis longus and brevis. However, the third compartment extensor pollicis longus. Sorry. Moving to the fourth compartment, which is containing the flexor digitorum, extensor digitorum and extensor digiti, extensor indicis. However, the fifth compartment on top of the radio-ulnar joints represented with the extensor digiti minimi. Ask your patient to slightly move towards the radial aspect to scan the extensor carpi ulnaris, which is represented in a certain bony groove after the ulnar styloid process, and this is a characteristic appearance named as Horus eye. So one of the most important recesses need to be scanned in the hand joint is the wrist joint. We all aiming to scan the wrist joint for any fusion or any inflammatory arthritis. So in such technique, either to put the hand of the patient relaxed on a table or a pillow, or you may do it dynamically by holding the hand of the patient and put the probe longitudinally in the wrist. These are the bony landmarks you need to appreciate: the radius, leonate, capitate, and the metacarpal bones in sequence. This is the important recess you need to identify while scanning: radioleonate recess, leonocapitate recess, and finally the capitate and metacarpal bone recess. Moving to the hand, again, we need to have the same setting. However, take care, you can avoid overcompression. The hand structure is so small that can be compressed easily and you can lose the Doppler signal. Hockey stick is a valid transducer in this setting. So the standard scan for the hand as well, longitudinal and transverse as any joint, volar and dorsal as any joints. However, the medial aspect and lateral aspect of each joint can be accessible in the hand joint, except in the MCB only first, second, and fifth joints can be scanned laterally. The checklist: tendon, flexor, and extensor tendon, as well as the pollicis system in the flexor tendon for trigger finger, and the dynamic assessment for the flexor tendon for any triggering or any abnormal movement. For the extensor side, the extensor tendon, lateral sagittal band, and the side for MCBs and ulnar collateral ligament. Again, patient position, probe position, and bony landmark. So relaxed hand on the table or in a pillow in front of you, volar or dorsal. This is the assessment of longitudinal scan of the extensor tendon in case of the MCB joint. You can appreciate the thickening of the capsule on the dorsal aspect. Don't appreciate this as an erosion. This is the normal notch in the dorsal side of the MCB joint. And this is the recess, which is away from the capsule. This is the site of synovial reflection for accumulation of fluid, and on top you can appreciate the extensor tendon as well. You should confirm your finding on transverse scan as we learned. So these are the extensor tendon on top, Again, to assess the cartilage, you may scan in flexion position for the MCB joint for any abnormality in this hypoechoic structure or any erosion in case of rheumatoid arthritis or other erosive inflammatory arthritis. And dynamic assessment at the site of MCB is important to assess the sagittal band rupture. In this case, you can appreciate the tendon in the center of the MCB head, however, here a little bit subluxed toward the medial aspect. After complete flexion, total subluxation of the extensor tendon between the heads of MCB, indicating ruptured medial sagittal band. Moving to the PIB joint, which is like slit-like joint, not like the MCB joints, with the extensor tendon on top and the capsule as well as the recesses in longitudinal and transverse scan. And DIB, again, a small slit joint, and you can appreciate the attachment of the extensor tendon at the base of the distal phalanx, which is a site of enthesitis in case of seronegative spondyloarthropathy. Scanning of the nail is important to appreciate the trilamellar pattern. Doppler signal also can be identified normally. However, exaggerated Doppler signal may indicate active inflammation in case of psoriatic arthritis. Moving to the volar aspect of the hand joint, transverse and longitudinal scan, you can appreciate the palmar plate and the flexor digitorum superficialis and profundus on top. And this is the hypoechoic line around the tendons representing the A1 body. This is the longitudinal scan. Again, this is the palmar plate, the flexor tendons, and the A1 body on top. Usually, you cannot identify A1 body easily unless there is a pathology. Dynamic assessment for the flexor tendon is crucial to identify any abnormality or triggering. This is ultrasound illustration for the attachment of the flexor digitorum superficialis as well as profundus and other enthesial sites. So again, to summarize, you should scan all the hand joints, longitudinal and transverse scan to identify any pathology, volar and dorsal. Don't forget the distal insertion for enthesitis. Another important site to be scanned, the thenar muscles for the abductor, flexor pollicis longus. You can identify it in transverse scan and longitudinal scan, fibrillar pattern, and also dynamically assessment. Lateral sides of the joints is important to identify erosions. This is an erosion in a case of rheumatoid arthritis on the lateral aspect of the MCB joint, both in longitudinal and transverse scan. So some pathological tips for the sake of the time. So effusion, it's compressible, displaceable, hypoechoic structure. So here it's compressible. This means this is fluid, not synovial hypertrophy or synovitis. Synovitis or synovial hypertrophy usually exhibit Doppler signal indicating active inflammation. So to differentiate between synovitis and synovial hypertrophy, you should do compression at the site of the joint. Another examples for synovitis in the small joints of the hand, longitudinal and transverse, in a case of rheumatoid arthritis. Doppler signal positive also in a case of rheumatoid arthritis. Wrist joint with active Doppler signal in rheumatoid arthritis. A case of GIA, juvenile idiopathic arthritis, showing also active Doppler signal and synovitis. Tenosynovitis is also characteristic. You can differentiate between wrist arthritis and tenosynovitis by ultrasound. This is a case of tenosynovitis on the fourth compartment, represented with the hypoechoic structure around the extensor tendon exhibiting Doppler signal. Tenosynovitis at the flexor tendons of the digits, also in a case of rheumatoid arthritis exhibiting Doppler signal. This is a case of wrist pain without synovitis and referred as a case of arthritis. There is abnormal irregularity at the site of leonate bone on the ultrasound, and MRI confirmed Cohen-Book disease. Another case referred as arthritis, and upon scanning there was an intra-articular ganglion within a hypoechoic round with circumscribed structure with posterior acoustic shadow. Identification of median nerve, and in case of carpal tunnel syndrome, either by cross-sectional area, which is variable between different ethnic groups, and you can compare to the proximal part of the median nerve at the site of pronator quadratus to appreciate the presence of carpal tunnel syndrome. CBBD and triangular fibrocartilage with hypoechoic dotted structure at the site of the triangular fibrocartilage. You should differentiate the erosion, which is the discontinuity of the bony cortex in two perpendicular plane. This is a case of rheumatoid arthritis. This is a case of psoriatic arthritis, and you can appreciate the difference that the psoriatic arthritis erosion are nasty and not smooth like that of rheumatoid arthritis. However, in extensive cases of rheumatoid, you can appreciate such erosion. Step up defect, this is an osteophyte, not an erosion, so you should differentiate between these two different findings. This is a young male with genetic gout and presented with tophaceous gout at the site of the lateral aspect of MCB, which is rare. Nail, different nail pattern. This is the normal nail. This is the nail with psoriatic arthritis with thickening of the nail bed, loss of trilamellar pattern at the nail itself, high Doppler signal reported in comparison to the normal. Bullies itself can be found in trigger finger, diabetes, idiopathic, hypothyroidism, but also as a functional enthesis in psoriatic arthritis, and can be identified with exhibiting Doppler signal as a site of early psoriatic arthritis. Ulnar collateral ligament, also one of the common sport injury and goalkeepers, and you should be scanned during ultrasound. So in conclusion, hand and wrist structure sonography offer high fidelity imaging because they are superficial structures. The hand is the target of inflammatory arthritis, enthesitis, and functional enthesis. Knowing the anatomy and sonoanatomy aid to refine the diagnosis, to exclude other concurrent pathology. Please, the important tab, you should train yourself more and more on normal individual before moving to pathological to identify the difference between the normal structures, pathological structures, and pitfalls. Thank you.